this in quite some time. 12,064 cases reported statewide again. Tuesday numbers a little lower, represents a lot of the Sunday data. 7-day average coming down now under 17,000. So positive news, still in the face of pretty robust testing, a little lower than when we'd been averaging about 350,000 tests a day, but also not unexpected when people are less symptomatic, feeling less sick, fewer people are rushing to get tested. So not a surprise. No issues with our sites or turnaround times, etc. So we believe that's a good, accurate number. 14-day positivity down to 7.2% as well. Next slide. Here again, you see an even lower 7-day positivity at 6.4%, a bit lower than that 7.2 at 14 days. And then if you compare 14-day test positivity as we do each week, you can see that we've had nearly a 40%, 38% to be exact, decrease over the last 2 weeks. Again, positive sign about the trajectory of transmission across the state. Seeing this in all parts, not just rural California, not just Northern California, but also the southern urban counties as well. Next slide. So we've been focused on hospitalizations, on ICU capacity for the last many weeks, nearly 2 months. We announced our regional stay-at-home order back in early December and been tracking this information throughout. So we've seen a nearly 29% decrease in hospitalizations for COVID over the last 14 days, 14,221 individuals in hospitals with COVID diagnoses as of yesterday. Additionally, good news, I've been sharing that we've been seeing about 4,000, upwards of 4,000 hospitalizations for COVID in a single day throughout the state. As of yesterday, we were in the 1,700 range for total hospitalizations, so more than half a reduction in new hospitalizations day over day compared to our peak. Similarly, this ICU number is a little bit harder to move. Individuals who need ICU level care with COVID often stay for quite some time. They're on ventilators, they're receiving other life-saving care to make sure they can get through the COVID disease. And so we're not surprised to see a slightly reduced, but still down number for ICU levels, now below 3,800 total individuals with COVID in our ICUs across the state. Number we're going to continue to watch, and I'll talk about in just a moment. Next slide. So here, a slide I showed a version last week to show where our projections are heading. We look at 4 weeks out, our total hospitalizations. This is not the ICU projections. I'll get to that next. We're anticipating that 30 days from now, so on the 4th of March, that we'll see fewer than half the number of people with COVID in our hospitals as we have today. Good news, continue to see that decline coming down. Of course, there are variables to this. This is based on conditions that we're seeing today. But if we start to see a reemergence of COVID in our communities, increasing numbers, these will change, of course. But based on today's information, our models coming together, we predict that fewer than half the people we have in hospitals today will be in hospitals 30 days from now across the state. Next slide. So a reminder that our regional stay-at-home order, which has been lifted statewide, really looked at our projections 4 weeks from now around where we'd be with our ICU capacity. Again, we built this around ICU capacity. It's not just the routine conversations on test positivity and rates of transmission or case rates, but we looked at this lagging indicator, but an important scarce resource across our state, which is ICU beds, ICU staff beds. But now we're seeing, when we do our projections as of yesterday, that 4 weeks out, we see Southern California, the hardest hit part of our state, that was well below zero in their ICU capacity, surging quite a bit in almost all of our facilities in Southern California. We now see that we project a 43.7% ICU capacity 4 weeks out. San Joaquin Valley, the next hardest hit region of the state, 35.1. 33.3 in the Bay Area, Greater Sacramento, also above 30 at 31.4, and Northern California, our least populated area, the area with the fewest ICU beds before COVID, still we project nearly 30% at 29.2% ICU capacity. Again, these four factors that you see on the right-hand side of this slide: current estimated ICU availability, community transmission rates, current regional case rates, and then the proportion of cases admitted to the ICU. Those are all the inputs that you can use to build into these calculations. You can see the historical data on past ICU capacity on the CDPH website. Later today, I'm not sure it's up quite yet, but this will go back to December 28th, the first day regions were eligible to be out of the regional stay-at-home order. Looking at the data, many of you will see some of those trends and how we landed where we are today, and certainly the information that went into lifting the regional stay-at-home order last week. We'll go to one more slide on this issue. Next slide, please. This slide, quite a detailed slide, but I think very useful to look at the various inputs to come up with our ICU projections. I used this last week, wanted to use it one more time to remind you that we look at the case rates in a region. We look at that R effective, that transmission rate, which, by the way, statewide is now well below 1. It's at 0.78 as of this morning. Again, good news, want to see that continue to come down, stay below 1, so that we end up seeing a reduction, a contraction of the number of cases in our regions and statewide. These two inputs give us that projected COVID cases. We then use that to look at projected new admissions, then new ICU admissions, and then with a bit of a formula of where people are being discharged at the ICU, compiling all of that, looking at our total occupied beds, our capacity, to then come up with a percentage projected ICU beds available in a certain region. I know, pretty complicated, but for those of you who've been tracking it, I think important for you to sort of get under the hood a little bit, understand how these projections are made. Again, some people want this to be in a model. We think of this as a projection, not a model. We use current inputs to determine what's going to happen 4 weeks out from now. A little different than the various models that have been used throughout the pandemic to predict transmission and other rates of infection. Next slide. So we've been talking a lot since the beginning about testing, about case rates, and watching various moments of the last many months when we had, quote, surges in cases. But over the past month, 2 months, we've been talking more about variants. These are, as I've reminded you before, different, the same COVID virus, but where the genes, the sort of blueprint for how the virus behaves might have a mutation here or there. And some of those mutations are meaningful and create what I call additional stickiness, more infectiousness of the virus, or in some cases, not the case here, as far as we know, but in some cases, mutations can affect the way a treatment works, the way a vaccine works, or even causing someone to become sicker because they have a variant strain as opposed to the wild type strain. We're continuing to actively sequence the virus here in California, building up capacity to do even more. We're watching the West Coast variant that we talked about a few weeks ago. Here we're seeing over 1,000 total variants between these two slightly different mutations of the same West Coast variant across our state. We reported both in Southern California, parts of the Bay Area, Santa Clara in particular, where this variant was being found. Again, unclear about its exact role in either making people sicker because they have the variant strain or its impact on things like vaccine or infectiousness. So stay tuned as we continue to learn more there. And then the UK variant, a variant that we first talked about Continue to see cases here in California, although not rapidly increasing in the number that we're finding, still at about 133 cases identified across 5 counties, largely in the southern part of the state. So we'll continue to watch this. I know many of us believe this is an important detail, watching not just do we have COVID in our state, helps us through testing, but this sequencing element, understanding what type of what type of COVID strain we're contending with, and will that change how we address and behave in any of our pandemic response elements. Next slide, please. So as we talk about case rates, we talk about the future projections, we look at things like the variant. It's an important time to talk about fundamentals. Masking matters. We've been talking to you since nearly the beginning of our pandemic response about the use of face coverings, surgical masks, for some, the importance of an N95 respirator. These are all different ways to protect ourselves, our communities, our households from COVID transmission. We know that one of the most powerful tools we have to reduce COVID transmission, they protect both ourselves as a wearer and others around us. And what they do is block or filter out the virus that's carried in aerosols. So what do you need to know different today? That we really want you to pay attention to the material that your mask is made out of. Some masks, more surgical masks or procedure masks, often the blue masks with the white ties. I have one here. Many of you have them or have seen them around. They're a high quality mask that does do more often than face coverings. They often come with a metal tab that you can firmly put it around your nose. Another important aspect is making sure that your mask covers both your mouth and your nose, that it fits snugly around your mouth and nose and around the rest of your face so that air doesn't easily move in and out of your masked areas. And that doing this and wearing a high quality mask consistently over your mouth and nose when you're outside of your home, when you're at work, when you're with other people that aren't in your household. But for some of us, and in high transmission communities, in households where it's hard to protect vulnerable individuals, those with underlying conditions, those who are older, those who frankly we're prioritizing to get vaccinated if they haven't yet been vaccinated, and even when they have, trying to wear your mask around them until we get our case numbers down much lower. It's a good way to protect yourself, but also loved ones in your household so that they can be protected from COVID-19. I often think about this moment as I think about the fourth quarter of the situation that we're in, now that we have a vaccine, that it's an important time to remind ourselves of these fundamentals, to remind ourselves to do them as much as we possibly can. I know in my own community, I see more people milling around, less masking than I would like to see, less masking than we saw maybe a couple of months ago. And it's a real opportunity to up our game on this point, to increase our ability to protect ourselves and our families and our communities at large as we try to move through the pandemic. So as you can, I know these have been politicized. There's been a lot of tense conversations about masks, but as we enter this sort of final period, do what you can to mask up and protect yourselves and your communities. Next slide, please. So the next part is really just talking about vaccines, and been on everyone's mind, certainly been the major work effort that I've been a part of, our team at this state, not just in public health or health and human services, but broadly the work of Secretary Yolanda Richardson and GovOps and many, many others, all across state government, partnering with county partners, other healthcare delivery partners, community-based organizations to continue to build up our ability to get more and more Californians vaccinated. As we've said before, the only rate limiting step to vaccinating Californians should be the availability of the vaccine itself. We continue to work with the federal administration, the manufacturers directly, to understand what can be done to get more supply to California as we really build up our capacity. The Vaccinate All 58 campaign, really a partnership with all 58 counties, working to make sure that we do what we can to get every county, every corner of our state vaccinated through our efforts. The announcement now, myturn.ca.gov, we talked to you about this before, a new state program partnering with certain counties as well, LA County, San Diego County now up and running, but really statewide, a program that you can go and try to understand when it's your turn, register to be reminded or notified when it is your turn. And in fact, if it's your turn to receive vaccine now in certain counties, San Diego, LA, later on, statewide, you'll be able to register and get an appointment. The nice thing about myturn.ca.gov is it's also an opportunity to seamlessly move information about vaccination into the state database so we can know who's been vaccinated and continue to make sure we're reaching all Californians to get vaccinated. It also helps us communicate to our federal partners at the CDC the level of our use of vaccines in the state. We've been working hard around the clock on the data issues, as you'll see in a future slide, getting more of that data in a timely way so that we can notify all of you. We can track our own efforts, make improvements as we go, and also notify our federal partners about the level of vaccines. So check out myturn.ca.gov, and we'll keep you updated on how this tool can really help us in our efforts across the state. Next slide. This slide is really one I've shown you before, what we call our epidemiologic curve, where infections from testing, as we get more information from our test volume, it comes in a little bit late, but we're able to attribute on a specific day when a test was taken so we can get a sense of how the disease transmission has gone. This is not that curve, but it's similar in a way. This shows our ramp up. So if you look on the left side of this graph versus the right side, those lower bar graphs versus the tall ones on the right, that's essentially been the ramp up of California's vaccination efforts day over day over the course of the last approximately 8 or 9 weeks since we started vaccinating Californians. Not surprising when supplies were low, when we had fewer providers administering vaccine during the holiday season, when we were in our most difficult, challenging surge, and those same providers in charge of vaccinating Californians were taking care of Californians in need of life-saving care at the bedside. But as we've come out of that surge, increased our ability, like the train picking up steam, you see that I'll remember a day right before we started our 10-day challenge. Back in early January, we were doing approximately 45,000 vaccines a day. We had a peak day of over 180,000 vaccines done in a day. More than 3 times, closer to 4 times the level of vaccination that we were doing in the early part of January towards the end of the month. So certainly picking up steam with that. Proud of the efforts and the work that the state team has done to work with our county partners, their tremendous effort to organize the vaccine work, both at mass vaccination sites or other events, as well as working with the traditional vaccinators like clinics and hospital systems and others to get Californians vaccinated. Next slide. So I wanted to take a moment, and the last slide really talked about how we're beginning to speed up across the state, and all very good news, and thank so many leaders who've had a hand in helping us get there. But advancing equity continues to be one of the key efforts around our entire pandemic response, but also with vaccinations. And I want to start by talking about this notion that there's a choice that we have to make between speed in vaccinations and equity. This is not a choice. This is a false choice. We can do both. Equity, in fact, to achieve it with vaccination requires speedy vaccinations. We cannot wait long to vaccinate those communities that have been disproportionately impacted by COVID, those communities that may have historically higher hesitancy to vaccines and healthcare services, where access is not as robust as it is in other parts of our state, where the time when vaccines happen matters, that people who work long days on the front lines in essential places, who come home exhausted and tired, may need late night options, convenient options in other locations. So all of this is part of the speed that goes into an equitable distribution of vaccine. So as we work around racial equity, as we work to touch Californians who have underlying conditions or functional needs or severe disabilities, to make sure that we create touch points and opportunities to have vaccination be easy when that time comes. So looking at some key strategies, pay for performance, a sort of clunky healthcare term, which really means incentivizing people and paying them, those who are doing the vaccinations, to do well, do thoughtful vaccinations in partnership with communities in some of those hardest hit communities, supporting those vaccination partners to do work in communities of color, making sure that we're providing resources necessary to do the targeted outreach and engagement with community-based partners, the faith-based community and others, to make sure we're targeting the right individuals. We've talked before about using our allocation strategy to make sure the hardest hit communities receive vaccines sufficient to reach many of their population, and then using our ability to create non-traditional sites, as I mentioned, education opportunities, so that we can really put our best forward to get those who've been shouldering the burden of COVID vaccinated in the right quantity, so we can really end this pandemic in some of our most hardest hit communities. This is something we'll continue to talk about. This is really part of what we've talked about with the blueprint. You'll remember our health equity metric, something that we built around focusing our testing, not just our testing supplies, but the result of those testing, the test positivity in hard hit communities, our lowest quartile healthy People's Index communities across the state. So continuing that focus on our health equity metric, building that into our vaccine strategy, and really pushing this forward with so many partners to make sure Californians are vaccinated in that equitable way. Next slide. Continuing on this front, public education campaigns focusing on use of trusted messengers, trusted professionals who can communicate effectively with communities that and populations that often have some degree of vaccine hesitancy, making sure we focus on in-language content with a degree of cultural humility that we expect for all of our healthcare services across the state. And we need to be laser focused here on the vaccine campaign, using ethnic media across the state to reach a lot of audiences that hard to reach because we don't always have material and education materials, in particular in language, using live reads, essentially providing scripts to individuals who can reach a number of folks across our state who maybe can't tune in to some of the English presentations or even some of our Spanish presentations, making sure that we touch way beyond the traditional languages that we often focus on, but to these 40 different ethnic outlets, 18 different languages. And I want to take a moment now, our very own new California Department of Public Health Director, Dr. Tomas Aragon, did do a public service announcement around vaccines in Spanish. I wanted to share it with you now so you can get a bit of a taste of what we should see, not just on cable networks, but hopefully on our other networks across the state.
Las vacunas de COVID-19 están aquí. Son recomendadas por expertos médicos de California porque se ha comprobado que son altamente eficaces y estarán disponibles sin costo. La vacuna de COVID-19 puede ayudar a protegerte a ti y a tu familia y acabar con la pandemia. Y recuerda, sigue usando mascarilla aún después de vacunarte. Para más detalles visita vaccinateall58.com.
And as you can see, that in Spanish public service announcement not only focuses on the way and the need to get vaccinated, but it focuses on keeping yourself distanced, keeping your mask on, and making sure we don't put our guard down as we get more and more Californians vaccinated. So thank you very much, Dr. Aragon. Also, you might have seen one in English by our own Surgeon General, Dr. Nadine Burke-Harris. Both are streaming or can be seen on our networks across the state. These are just the beginning, more to come with greater partners as well. Next slide. So as we've done for many Tuesdays over the last many months, it's also time to talk about our blueprint for a safer economy. Because of the lifting of the regional stay-at-home order, all counties, all 58 counties re-entered the blueprint. We updated last week most in the purple tier. Again, this week, the same situation. A reminder that this is our way to loosen and tighten restrictions across the state. It's county by county, unlike the regional stay-at-home order, which was 5 regions. We look at test positivity. Just showed you earlier how that's coming down across the state. Adjusted case rate, adjusted based on test volume. And then the health equity metric that makes sure that we are looking equally across our communities, focusing even more heavily on those communities with a disproportionate impact of COVID so that we leave no one behind. Next slide. So today's update, we see a couple of counties, small ones, Trinity and Alpine, moving from red to orange. 54 counties are still in purple, 1 in red, 3 now in orange, 0 in yellow. Many counties, because of the rapid decline of case rates, test positivity, we're seeing more eke into that 1 week eligible to move forward. Remember, we still require you to be in your tier for at least 3 weeks, and you need to have 2 consecutive weeks of meeting the next least restrictive tier. So if you're in purple, that means the red tier, those metrics before you can move. So we're starting to see more counties meet that first week. Look forward as we hold on to these reductions in cases that we see more counties move through that blueprint. Next slide. Also wanted to, because the less than 25 case rate has meaning now because of the focus on schools and the conversations around bringing young people back to in-person education. Here's a list of counties where the case rate is less than 25. We will periodically update this, but remember, all of this information can be found starting on Tuesday each week. It stays up the whole time on our CDPH website, some of it on the covid19.ca.gov website as well. If you're interested, please go there. Again, a list of counties with case rates that have already dropped below 25. You'll remember just a few short weeks ago, the state itself was knocking on the door of a case rate of 100 per 100,000 per day. So good news to see a number of counties below 25. Next slide, please. Before wrapping up, it would be a missed opportunity to talk to you about this upcoming weekend and other events. We saw around Thanksgiving, the weeks before Thanksgiving, even with Halloween, some major sport events, some success in the Southern California region with the Dodgers and the Lakers winning, that was the beginning of a surge that led to a lot of death in California, a really hard and dark period. And we now have another opportunity to keep our guard up and prevent the beginning of another story of increased cases. So we want to see around the Super Bowl an exciting day, an exciting event for many, one that was even last year a big moment for gathering and coming together. But we want to make sure that this Super Bowl does not become that next big spread event, that we do what we can and keep our guard up. I know it's hard. I know many people looking forward to gathering, but as much as you can, let's not have the Super Bowl become the next beginning of a huge surge here in California. You can celebrate the game, watch it with your household. And if you are with people, another household in the backyard watching it, keep your distance, keep your mask on, try to share as little as you can, except the cheers of the game when it's appropriate. So as it says here, don't fumble this. We're almost there. Let's keep our guard up a little bit longer. And just thanks in advance for everyone's effort on this point. Next slide. And then soon after Lunar New Year, the following week, again, a chance and an opportunity for many Californians to celebrate as we have in prior years, but this year it should, and I hope it does look different. As much as you can avoid in-person gatherings, continue to support and celebrate with your family as we have in other moments virtually, making sure that we don't end up mixing with loved ones that we haven't seen in a while, because that is, as I've said before, you give COVID an inch and it will take a mile, and we don't want to see this yet another chance to see the increased spread across our state. Never miss an opportunity to end with wear your mask, try to keep your distance, wash your hands, and as much as you can, keep your mixing, especially in larger crowds, to a minimum. Next slide. So we've said this now for the last couple of months together. We can slow this spread. We can end this pandemic. The promise of vaccine, the fact that California is beginning to see increases, not just in our vaccines, but in our ability to capture the data, document it, show all of you that we're beginning to pick up steam, and that we need to get more vaccine here to help support us to get through this pandemic and end and return to many of the activities I know we all miss for the last many, many months. So with that, I'll take the first reporter question.
Stephanie Sierra, ABC7 Bay Area.
Hi, Dr. Ghaly. You said today we don't have to make a choice between speed and equity when it comes to vaccinations. Yet the state is not releasing any race or ethnicity data to show what groups are getting vaccinated. We know the CDC has started. So can you explain why this isn't happening? And if it is, why hasn't it been made public yet? I do realize the initial data won't paint a complete picture yet, but experts are arguing it's a necessary starting point.
So, and we recognize it, and really to track our ability to reach communities of color, communities that have been disproportionately impacted, we have to have that data. We're working on it with our local partners to make sure that we have as accurate as you can. I'm glad you pointed out it's going to be incomplete at the beginning. It will continue to get better. That transparency is important. It's helpful to us to make sure we pinpoint our activities. So stay tuned. I'm not exactly sure when we'll be releasing it. We want to make sure that we release as complete a picture as we can, and then we'll be able to share it with people publicly. But again, this notion that in order to do speedy vaccination, we can't do it equitably is one that I will argue against. And we will continue to work to make sure whatever data is released, that we see it as a starting point, something to improve on, and our focus on equity and vaccinations will help us track how well we do.
Anna Berry Jester, Kaiser Health News.
Hi, Secretary Ghaly. Thanks for your time. I was curious, with the arrangement with Blue Shield and Kaiser Permanente, which challenges specifically are you trying to solve in the current state system? And then additionally, when you're talking about these health equity metrics that will be a focus, do you have any sense of what amount of payment you'll be offering providers and what specific metrics you'll be using? Thank you.
Yeah, thanks. And thanks for the question. I'll just say that Secretary Yolanda Richardson, thanks for her partnership, her team's partnership. She's working hard around the clock with our partners on the third-party administrator agreement. She'll be here with us next week to answer more specifics on those questions. Of course, what we're looking forward to do is continue to build on the success that we're seeing over the last many weeks, make sure that we have that statewide network that can address not just the challenges of the day, but also the future, where we need to be able to do greater amounts of vaccinations per day and really build up our capacity. So look forward to her update and continuing that work. Specifically on your question on equity, really focusing on how do we make sure that we have enough vaccination sites in the hardest hit communities? How do we work with providers who are doing things successfully and in a speedy way to have presence in those communities? How do we use dollars to incentivize the relationships between the traditional vaccination entities and the community-based organizations, the faith-based organizations that are so vital to getting the word out, engaging people in a meaningful, trusted way? So each of these things are going to be the categories. The metrics we're going to look at are rates of vaccination in the hardest hit communities, our ability to keep supply going to the communities, our allocation strategy. In terms of specific amounts, not clear. Frankly, I think the state's attitude is we need to do what we need to do to get as many people in hard-hit communities vaccinated. So we'll be working on that, and Secretary Richardson may be able to shed more light on that as soon as next week.
Prager, San Jose Mercury News.
Yes, thank you, Dr. Ghaly. Speaking of the hard-hit communities of color, we know when food and agricultural workers will get a dedicated vaccine allocation. They're in 1B Tier 1, and on the state's dashboard it says vaccinations for 1B Tier 1 are underway, but the Monterey and Salinas, Santa Clara, other counties in this part of California haven't yet released the allocations. And there's a perception that, because those over 65 are getting prioritized, that others are getting pushed back in the queue.
Yeah, again, thank you for the question. And as you sort of notably pointed out, some counties are, because of their strategy and their approach, they've been able to vaccinate some groups in front of other counties that are getting to them soon. I know that there is counties have the option to begin vaccinating individuals in the food and ag industry, our farm workers, those essential frontline individuals who are helping keep food in our stores and on our tables. Very important. We are working towards having, through really partly hinged to our third-party agreement and administrator, to be able to ensure that statewide there's some consistency of when that happens. Right now, we know counties are in different places based on the types of events, the types of providers in their network. This is one of the benefits of a consistent statewide network, where we can monitor and be able to support to make sure all areas are able to vaccinate all eligible populations. But we know, even when we do that there'll be more Californians in those eligible groups than we'll have supply for. And I'll continue to remind each of you and all of us that the supply of vaccine, we acknowledge that that's going to be our rate limiting step. We always hope for more. We continue to work with the federal administration to push for more, but that will be one of our biggest challenges. So communicating our focus on equity, our focus on the hardest hit communities, the hardest hit sectors, those most vulnerable with serious health conditions, over the age of 65, those with certain severe disabilities, making sure that they're prioritized, but knowing yet still we don't have enough vaccine to reach everybody at this time, and trying to help support everyone through my turn and other efforts to understand when their turn comes up and how they might get vaccinated when it is their turn.
Joe Cohen, The New York Times.
Hi, Dr. Ghaly. Thanks so much for taking our call. I wanted to kind of go back to the Blue Shield and Kaiser Permanente deals. I'm wondering if there is anything more that you can say about what those contracts entail, and in particular, can you say whether those the work that those providers or those companies will be doing will be in coordination with the My Turn rollout. How does the My Turn rollout fit into, those processes? Just, can you give a little more clarity on what those deals are?
Yeah, and I can't say a lot more in part, and this is where I'm so grateful for Secretary Richardson's work as I and our team continue to work on sort of some of the day-to-day issues, achieving equity in our allocation and administration strategy. She and her team are largely leading the way on that contract, those negotiations. So again, next week should have a lot more information to share with you on the status there. As it relates to My Turn, certainly the My Turn platform, not just because of its ability to let people know when it is their turn, not because it's a scheduling tool that can be used, but in part because it's going to be critical to our ability to get data into our systems in a timely way. It will, of course, be important to Shield and Kaiser and others to make sure that it's something that's adequate and it works well with our system. So, they are separate issues, but they do come together because they're important to be able to track and hold each other accountable. So I'm sure it will be a prominent piece of the conversation moving forward.
Claudia Peshueta, KNX News Radio.
Hi, thank you. Sorry, I'm laughing. It's Petsuda. Given the threat posed by new variants, how likely do you think it is that we will see another surge in California this spring? And if so, what's the state doing to prepare for that? And then this one goes way back to last April when the governor asked coroners across the state to review deaths going back to December to see if COVID-19 fatalities went back farther than we thought. And I'm wondering whatever came of that. Thank you.
Sure, thanks for both questions. The second one, I'll have to get back to you. I know that we did get some coroner reports from as early as the early part of January where COVID was suspected, confirmed in some, but I don't have complete information. We can get back to you. In terms of the variants and frankly, the wild type virus, what we've been sort of calling COVID-19 the whole time, the chance for another surge in California is real. It's still circulating. COVID is in our communities. Our case rates are down, but they're not low. We were, before we started to see the fall winter surge happen, we were seeing most counties knocking on the door of the red tier. Remember, that's 7 cases per 100,000 per day. That's much lower than we are now. Today, I published a list. Really happy to see a number of counties below 25. That's still 3 times higher than that threshold. So it's just a reminder that COVID is still abound in our communities. We've got to keep our guard up. How likely is it that we'll see another surge? I think, again, it comes back to the behaviors and our own sense of personal choices and personal responsibility on this. The variants, of course, create another wild card, another unknown. Those that are more infectious because they bind to the human cell a little bit more and they get into our cells and begin to replicate and make people either sick or at least able to transmit the virus. Those are real concerns. So we'll be watching very closely the level of and tracking the variant across the state with enhanced sequencing efforts. So together with testing, with sequencing, with watching the trends, and frankly, not putting in the closet all of the different things that we did in this last surge, things like the public health order to work with our hospital facilities to make sure that we're able to transfer patients between facilities when we need to. All of the work on oxygen and preparing our facilities to be able to deliver all of the services to patients in need, ensuring that we're able to allow people who can go safely to lower levels of care and discharge from the hospital. That happens immediately. Many of the different efforts that we talked about, getting staff into the state, not just staff for the ICUs, but for our clinics and our hospitals to help with other things like monoclonal antibody administration. All of these things that we've recently done, we're not closing them down. We may not talk about them as much, but we're keeping them sort of alive and well in case that surge happens again, in case a community is hard hit. So we feel confident because of what we just went through that we have the capability to serve Californians again, even in the face of the surge. But I'll end where I started, which is it really is going to depend on how much we keep our guard up, do the things that we have seen as we see the number of people vaccinated, the number of people with that level of protection increase day over day in our state.
Lynn, the Los Angeles Times.
Hey, Dr. Ghaly, thanks so much for taking our questions. I have questions for you today on vaccine eligibility for those with disabilities and variants. First, piggybacking on Lisa's question, there's been a lot of pushback from advocates for the disabled that they are being left behind in this new age-based rollout. Can you elaborate if there will be any special consideration for those with underlying health conditions or disabilities? And second, piggybacking on Claudia's question on the variants, can you list the counties that have confirmed the UK variant? And regarding the two West Coast variants, this is the first time I recall hearing of a second West Coast variant. Can you talk about both of them and whether you've determined they are actually more transmissible or more deadly? Thanks so much.
Okay, yeah. So the first one on the variants, they're just considered similar, same variant, just different point mutations. So they're listed as different on the West Coast variant. They end up still, I'm not, others may be, and we can update you, clear. I know they're looking at that variant to determine whether it is in fact more infectious, similar to the UK variant. It's actually a mutation in a similar area on that spike protein that binds to the cell. So it could certainly have a bit more infectiousness than the wild type. In terms of the counties, for the five counties, largely Southern California counties, San Bernardino, I believe Riverside, San Diego, and Los Angeles County. The fifth is escaping me, so we'll have to get that back to you, Ron. And then in terms of the question on those with disabilities and the sense that they are being left behind, I have myself been spending quite a bit of time over the last week, 2 weeks, working with various stakeholders on this issue. We are leading our vaccine effort by focusing on protecting those who have the highest risk and those who may suffer the worst consequences from COVID. So working with the disability community, working with those who take care of individuals with serious chronic conditions, beginning to galvanize around a policy that we will announce later that brings together an opportunity to vaccinate those individuals, all in the same vein where we focused on those older Californians, those with some of the most significant exposure, so that we continue to save lives in California, not just with our actions, not just with our hospital capacity, but also now with vaccines.
Kathleen Ronayne, AP.
So two topics. First of all, I just want to clarify based on what you just said that it sounds like some type of new plan will be coming out soon for how we are handling vaccination for people with disabilities, and you have a timeline on that. And then second topic, can you describe in a little bit more detail how and why the state decided to choose Blue Shield for this new partnership? Did other companies have a chance to apply? Was this something that was sole source? And do we have an estimated cost for this? And what is it going to mean for people who are already waiting for appointments through the hospital counties, their counties or pharmacies under the existing system?
Yeah, so on the first part of it, first, thank you for the question. And on the first part, working now and actually spending time bringing together a number of the different stakeholders, advocacy group, provider groups to determine the best way for us to ensure that those with serious disabilities, severe disabilities, and severe underlying conditions do get access to vaccine in an equitable, thoughtful, planned way. So beginning some of those conversations more intensely, and that will help us drive the timeline as to when some larger consideration is announced. And also, as I said in an earlier response, the availability of vaccine, always top of mind on these issues, making sure that we're able to both successfully and adequately deliver on the promise of adding additional people onto our eligibility list. So working hard on that, and not just working within state government or county government, but broadly with a number of stakeholders. I myself personally looking forward to making sure that we have a plan that focuses on equity, focuses on access, and meets the unique needs of those various groups. With regards to the SHIELD questions, again, better left for Secretary Richardson to talk through the process and how we arrived to these decisions and this point. For your last part of your question, part of the transition, part of the collaboration, part of this notion of building upon what has already been put in place in our counties and with other providers is to ensure that those who are queued up, ready and waiting to get their appointment, to get their vaccine, that we do not disrupt in this transition period any of those appointments, any of those promises that have already been put out there. We know that Californians depend on consistency and reliability, as they should, and ensuring that these transitions and these augmentations don't disrupt that in any way.
Final question, Victoria Colliver, Politico.
Hi, Dr. Ghaly. Speaking of vulnerable groups and those at high risk, we haven't heard a lot lately about the homeless and incarcerated populations that were supposedly in the second tier of phase 1B. And I was wondering, so where's the state on that in terms of focusing on those groups? And then the other question is the state actually issued guidance for the first tier essential workers in phase 1B, like more detailed guidance? Thank you.
Yeah, thanks, Victoria, for the question. So the guidance on the specifics of the first tier, tier 1 of 1B on the sectors is coming out shortly. Those specifics of exactly who is in those groups and some more specifics that is being worked on actively and will be posted shortly, hopefully between now and next week. You will see that available and announced in a different setting. In terms of the vulnerable populations, both the homeless and those incarcerated, important populations that we're working with our county partners with to determine how and when to vaccinate. Again, the focus on the most vulnerable in those populations, those who are over the age of 65, of course, and as soon as we get through some of the additional stakeholder engagement and planning around those with disabilities, functional needs, and those with serious underlying conditions that do lead to bad outcomes with COVID-19. So stay tuned on that piece. Nothing specific or concrete at this moment, but certainly an important group that we and our local partners see as an equitable part of vaccine distribution across the state. So with that, thank you all for tolerating another long conversation, but I hope useful information for many of you. Always happy to hear and answer the questions on the minds of our reporters as they communicate broadly to all of us how our pandemic response is going. Again, keeping in mind about this weekend Super Bowl, Lunar New Year right after that there's an opportunity for us to make decisions again to protect ourselves, our households, our families, and our communities. And I look forward to week over week, now that we're in this moment of vaccinating our communities, seeing the trends come down. I hope and continue to hope that we'll see those trends come down even farther so that we can begin to enjoy some of those activities that we all miss very, very much. So with that, have a good rest of your afternoon.